time. The issue of co-payments in the PBS. Now, you say that there should be a co-payment for pharmaceuticals because it's, and to use the language in the document, that it's important that people value the medicines that they're getting, and implementing a price signal is a way of forcing people or a way of ensuring that people value the medicines that they are getting.
True.
So how do you explain the fact that one of the biggest problems we have with our pharmaceutical system at the moment is that co-payments are acting as a disincentive for people filling their scripts? That's a fact. It's been demonstrated by a number of peer-reviewed research papers. The problem is that people are facing co-payments at the moment, therefore they're not getting their scripts filled, therefore a blood pressure medication is not being taken, and the likelihood of a stroke increases and they end up in hospital. So your solution to an existing problem, which is that we're already facing high out-of-pocket costs for PBS medicines, is to increase those costs?
Again, we're doing it on the basis of those who can look after themselves should, and those that can't look after themselves or have less capacity would pay a significantly lower amount.
But the evidence is the existing amount. You're suggesting an increase to the existing amount for both concessional and non-concessional people.
We say for concession card holders there will be no increase to the co-payment, currently $6 below the existing threshold of $360. However, the Commission considers that introducing a co-payment would be an important step in providing signal to users about the cost of their care and place greater value on those medicines, potentially reducing the incentives that users face to not take their medicines.
But how is it that we've already got a co-payment and it's not acting as an incentive for people to take their medicines? Well, we've got that in place at the moment in the PBS. It's a good example where we're seeing people not fill their scripts because they can't afford it. And you're suggesting that the co-payment is a price signal that somehow ensures that people see the value in the product that they're getting, when that's not what's happening at the moment.
Well, I didn't see that particular evidence, and again, in terms of the PBS, it's another one of those areas where we recommend that the Minister for Health certainly has a detailed look at the implementation issues. But again, it is a cost-saving measure for the Commonwealth to increase the co-payment in PBS. But the other side of the PBS, of course, is more important, is really, are we getting the drugs in the PBS at the right price?
It's a good, and I think that's probably the area we should be focusing on. Now, one of your, and I understand the work that you've done there, some interesting proposals. One of them is that when we list a new medication, that we should no longer list an older medication, so that we're trying to ensure that the total number of medications listed is... Now, how is it that listing a new, more expensive medication and removing an older medication that might be off patent that costs the taxpayer less is going to save money? That one's really got me beat.
What we're trying to do there is, and it's maybe a bit of a blunt instrument, is that the list of items covered by PBS seems to be growing inexorably, and there doesn't seem to be any pressure on the administrators of the scheme to rationalise the list as new drugs become available and old drugs become less relevant or what have you. And this is sort of a one on and one off mechanism to make them focus on what do we really need on the list. We need to... There doesn't seem to be any cap on this. There seems to be, like, the PBS, what's covered by the PBS just grows and the cost of it grows, and there's no sort of rational assessment of whether it's needed or not. And
agree with
this is our suggested mechanism for doing it. It may be a bit of a blunt instrument, and there may be some more sophisticated way of doing it. I agree with you, that should be looked at.
Agree with the challenge, but we're not talking about... We're talking about a very specific recommendation, and this is where I think we get into trouble here. Is you're making a recommendation that we delist cheap medicines in favour of more expensive medicines. So Mrs X, who's been on a cheap generic drug, is no longer able to take that drug because your recommendation says that that medicine should no longer be listed, and instead they should be moved on to much more expensive new medication. It doesn't make any sense as a cost containment measure. I agree there are challenges in the PBS, but the recommendation makes absolutely no sense.
Well, you know, we believe that it does make sense. We have discussed it with health people and they seem to think it makes sense, but...
Who did you discuss it with?
With the Department of Health and with people in the industry.
Was this their recommendation?
This was our recommendation, this is our device, but we were assured that it made sense.
Let me talk a little bit about the issue of, which is I think one of the really, some would say radical, some would say courageous, some would say perhaps less generous words. The issue of basically someone on over 88,000 no longer having Medicare as their primary means of insurance and effectively taking up private health insurance. Is that a fair summary of what you're proposing?
Yes, that's a single person.
Yeah,
single person.
So
no
a single
dependents.
person on 88,000 really is now covered by private health insurance, and that covers all the services that were previously covered by Medicare.
Yep.
So the first thing that occurs to me is, so you've got someone on over $88,000 who's paying the Medicare levy, who's paying income tax, who's paying for the healthcare in this nation, and you're saying, well, they should no longer access it.
Again, we come back to this fundamental theory and philosophy, is the current health system as it's currently constructed and growing is unsustainable. It will put an unreasonable burden on the taxpayer.
No one's suggesting there's no challenges. We're talking about the specific recommendations.
So therefore, this recommendation is designed to say to people who we believe should be able to afford to look after themselves, you will look after yourselves through private health insurance.
But they're paying for their healthcare through their income tax and through the Medicare levy. You're saying we're going to force you to pay for healthcare.
That's exactly. Okay. We're saying that because.
So you're paying for it twice.
We're saying, well, they're paying their taxes for sure, but the current system is unsustainable. We must get those people who can look after themselves to look after themselves. Now, we do stress, though, in doing that, we need to have a thorough review of the private health insurance market to ensure that we do not get unintended consequences. We do not want to end up in a US-style medical system.
How is this different, by the way?
No, well, that's exactly why we need... How is this
different?
We need to review the private health insurance market and how it is incentivised to contain costs and to contain their premiums and what have you. And I think that will need to be regulated.
But this is the US-style health market you're advocating for. I'll just perhaps put to you that the reason costs are contained at the moment is because we have a single insurer called Medicare that sets the price. It's a price setter.
Yeah.
What you're proposing is a number of competing private health insurance companies that can no longer set prices. The prices are then set by the service providers. That's why it costs a lot more for a hip joint done through a private hospital than it costs in the public system, because you lose the capacity of Medicare to control costs. So what you're proposing is to take that price cap off and to effectively end up with the US-style system where healthcare inflation's out of control.
What we are suggesting is, before you go down that route, have a very careful look at the private health insurance system and ensure that if you go down this path, that you don't end up in that situation, that we get a proper market, that it is competitive, and that the private health insurers are incentivised, as Medicare is, to keep the cost under control.
But why would
See, what happens in America is, because the health insurance is paid by the employer, it's an employer-driven scheme, the private health insurers have got no incentive to keep control of the costs of the services provided. I've been a part of the US system. I've seen it in action.
Yes, as have I.
And so I think the trick for Australia is to make sure, if we're going down this route, that the private health insurers are incentivised to keep the cost of service under control and to keep the cost of the premiums down.
But the thrust of your document... Yes, sorry, Senator Eccleston, we've agreed at the start of the meeting that we were going to go over time, so I've certainly got you in mind, and there'll be some questions for you shortly.
All right, thanks very much.
The thrust of your document is that we've got to remove duplication. There's a huge problem with duplication in government services, inefficiencies and so on. How is that different in this market, where you've got competing health insurers with competing administration systems, competing billing systems? You've got, of course, the advertising and the fact that these companies need to turn a profit. And you compare that with the single insurer like Medicare that's a price setter that can keep prices down, and that doesn't face the challenges of duplicating billing systems, duplicating administration systems, having to pay for advertising and all of those